We're so happy to have Guy Woolston with us from the Department of Social Services. But before we jump into today's presentation, I'd like to give an opportunity for remarks by the chairs and ranking members. And so since I kicked it off, I'll see if any of my folks are on. Senator Lesser, are you with us currently? How about Senator Lisa Seminara? I saw her, then she disappeared. Connecting to audio.
We can come back.
Okay, and then Representative Case, are you with us? All right, I'll turn it over to you, Representative Walker.
Thank you. Oh, Senator Lesser just joined us.
Senator Lesser, would you like to say a few opening remarks?
Well, I certainly don't want to jump ahead of Representative Walker. I just I'm looking forward to the Medicaid 101 this morning, trying to help all of the folks, members of the legislature, get our heads around a very large and important area of the state budget. I'm excited to hear from DSS.
Great. Thank you, Senator. Senator Seminara, would you like to say some opening remarks? Look, I think she's still struggling with the
Mike.
Right, I'll go over to you, Representative Walker.
Okay. I just want to say thank you for inviting us. And we do this every year because Medicaid changes every year. And it's important that we stay ahead of the curve because we have so many different programs in which address diverse populations in the state. So I look forward to hearing all about what we are going to be looking at in this session, and I'll turn it over to Senator Austin.
Thank you very much. It's a pleasure to be here today. And yes, Medicaid is an important component not only for the state budget, but it's also an important component in everyday people's lives. And it's important for us to make sure that the benefit that one can get from Medicaid is actually received by that person. And this allows other legislators to understand the importance of Medicaid and its value and who can benefit from Medicaid. So thank you very much for doing this.
Let's see. Senator Berthel, are you on? I don't see him. Representative Nucio.
Good morning, everyone. Thank you for this event today. I look forward to listening and learning. I know Medicaid changes all the time, so having these meetings is good so we all understand what's on the table. And I know we're going to have a really good conversation because there's a lot of talk about what we're going to do with Medicaid reimbursements this year. So I'm looking forward to listening and learning. Thank you.
Thank you. All right. So I'm going to toss it back to Representative Gilchrist or Senator Lesser, whichever one, or we'll take turns. But I would just ask, Guy, do we have any materials?
We do. I will share the slides, and then I'll email them out after. I'll give it to Chandra, and who can send it out after the meeting. Okay.
All right. Thank you, and thank you for the presentation. But we like to read it ahead of time, so just saying. Okay.
Oh, great. We can send it. So thanks for that. Thanks for that feedback, Representative. And maybe Bill, could you send when we get going? Maybe you could send the slides and send it out.
No problem. We'll go. I'm getting the look from the administrator.
Yeah,
Go ahead.
He's taking all of us by surprise right now. We don't get to read it ahead of time, Tony.
Madam Administrator?
Guy, if you could send it, the presentation, or Bill, if you could send it to both Chandra and I, that way it gets out to members faster.
Thank you. Thank you, everybody. Representative Gilchrist, take it away.
Great. The only thing I have to add is that we are going to hold questions until the end of Guy's presentation. So with that, I'll turn it over to you, Guy. Thank you.
Great. Thank you so much for thank you to the chairs and ranking ranking members for hosting this. I'm Guy Woolston. I'm the Medicaid director. I work at the Department of Social Services. I'm joined by my colleagues, Bill Halsey and Brad Richards, the deputy director and chief medical officer, respectively, of the Medicaid program. Really appreciate the time. And know that one of my key jobs is to help educate you and give you all information to help you make smart decisions in your role as legislators. And so we have this meeting today. This won't be the only time we interact, I'm sure. And I really look forward to helping you achieve the goals that your constituents expect you to achieve. I'm just going to share my screen, and hopefully I do this correctly. You all can let me know if we don't get this quite right. And let me just switch 1 second. Good. Does that look good to folks? Great. Terrific. And as Representative Gilchrist said, we do have a lot of material. What I thought we'd do is at the end of each major section, I'll open it up for Q&A. And if it ends up being too many questions, maybe 5 minutes at the end of each section, and then if it ends up being too many, maybe we'll have to just hold those to the end. We will have plenty of time for a Q&A at the end. So I'm gonna jump right in.
Guy, have you ever done a presentation for legislators and we could do it in 5 minutes with questions? Have you ever done one of those?
I do the presentation in 5 minutes and
No. Have you ever had us only ask 5 minutes worth of questions?
Never,
No.
Representative.
Okay, just ask. Okay, thank you.
Yeah. But my job is to serve you all. So I want to make sure I answer the questions that you all have. I'm going to start with the biggest picture. Husky Health, which is Medicaid and CHIP, provides health coverage to approximately 1 in 4 residents in Connecticut, covering about 1 million people in every town in the state. We provide coverage to people through all walks of life. 1 in 6 adults, 1 in 3 children, 2 in 3 nursing home residents, 3 in 8 individuals with disabilities, and 1 in 4 Medicare beneficiaries. So anyone who represents any part of the state has an interest in Husky and Medicaid. And as Senator Lesser said, in addition to serving people in every town in our state, it's also a really big budget item. The total spending on Medicaid, state and federal, including everything, including the certified public expenditures and hospital settlement payments and dish payments, is more than $9 billion. It's a really big budget item. Just a little bit of detail on how it works here in Connecticut. So the Department of Social Services is known as the single state Medicaid agency. We work in close partnership with several sister state agencies, primarily DMIS, DCF, DDS, and DOH, that have roles in managing particular portions of the Medicaid program. We partner really closely with the Department of Public Health. And then we deliver our program, and we're going to come back to this in a moment, working with 3 administrative services organizations, or ASOs. And these 3 entities down here are responsible for delivering the medical, behavioral health, and dental portions of the program. We also have a non-emergency medical transportation vendor. So there are a lot of players, but as Medicaid director and as a single state agency, part of my job and Bill's job as deputy director is to help play traffic cop. And so as legislators have questions about the Medicaid program, it's part of our job to help you get those answered regardless of where they fall. So it's a really great opportunity to meet all of you, and thank you again for attending. What I was planning to do was I was going to start with just some really high level context on the Medicaid and CHIP programs. We then are going to walk through 5 important facts about Husky. I'll then mention a little bit a big thing that's coming, the unwinding of the continuous enrollment portion of the public health emergency. And then, of course, we'll have Q&A. I'm going to start with the context. I want to distinguish Medicare from Medicaid. Medicare is a federal program that provides basic health insurance for people over 65 and people with a qualifying disability. Its main focus is on kind of the basic portions of health insurance, so hospitals, doctor's visits, and more recently prescription drugs. It provides much more limited coverage for behavioral health, long-term services and supports like nursing homes, and generally does not cover dental, and is funded at the federal government through payroll taxes and beneficiary cost sharing, like premiums and cost sharing. So that's Medicare. Today, we're talking about Medicaid, Husky, as it's known in Connecticut. That's a state-federal partnership. It's administered by the state, administered by us, by the team here, and it's partially funded by the federal government and subject to their rules. In terms of what it covers, it's expanded healthcare coverage for low-income adults and families, as well as elderly, blind individuals, as well as those with disabilities. It's comprehensive. The coverage, it covers medical, behavioral health, dental. It pays for the majority of long-term services and supports like nursing home or home-based care for people with disabilities or older adults. And as I mentioned, it's jointly funded between the state and the federal governments. And I'll get into the money on the next slide, but just know it in fiscal year 2022, the federal government paid about 65% of the total program costs, and the state paid the rest. So that's Medicare versus Medicaid. Here we're talking about Medicaid today. Just a little bit more on the money, because I know this is important in budget season. So Medicaid is jointly funded by the state and federal government. The baseline kind of bread and butter of the program, the feds pay a specific amount, and that amount is known as FMAP, the Federal Medical Assistance Percentage. It's a number set by federal policy, and states that are higher income have a lower match, and states that are lower income have a higher match. So Mississippi has a higher FMAP than does Connecticut. Just taking a big step back, one key advantage to administering a program through Medicaid versus doing it, outside of the Medicaid program is we receive federal match at least 50%, sometimes much higher, on any spending that we do through Medicaid that receives federal match. And so it stretches the state's dollars much further. We can serve more people. We can have a richer benefit than we would without that federal match. So here's the details on that match. So as I mentioned, higher income states like Connecticut, also many of our peers, receive 50% match from the federal government on every dollar. During the public health emergency during COVID, that's been upped a bit to 56.2% that will unwind over the coming year. So that's the baseline. Some portions of the program get higher match. So Husky D, which is the Medicaid expansion population, kind of the Obamacare expansion population, is matched at 90%, as is family planning services. And there's some other smaller elements that are matched at 75%, some of our technology, et cetera. So overall, our match rate in state fiscal year 2022 is 65%. So that's Medicaid. Husky, the brand Husky consists of Medicaid, and that's the most number of lives. And then CHIP is smaller, but it's an important portion of Husky. CHIP stands for the Children's Health Insurance Program, and it's similar to Medicaid. It's a federal-state partnership. It covers uninsured children and families who are modest but a bit too high to qualify for Medicaid. And I'll have the income limits on a future slide so you can get a sense of who's covered. Unlike Medicaid, CHIP is not an entitlement program at the federal government. It needs to be reauthorized every year. Under federal law, states are permitted to require financial contributions from families participating in CHIP, and we do here in Connecticut. So they pay a little bit of money. And the federal government pays for normally 65% of CHIP, recently 69.34% due to the public health emergency under COVID. So let me pause. I'm gonna switch gears and talk about kind of 5 key facts about Medicaid. I just want to make sure if I've lost anyone or if anyone has like a foundational question before I get started, let me pause and open up at least for a moment for questions.
Can I ask a question, sir?
Please.
Yes, Guy, could you just, you said we are an ASO. Can you tell us a little bit more what an ASO versus what are the other options that states have out there, please?
Great. Yeah, and actually we're going to jump to that.
Oh, no, don't jump. Never mind.
Sure?
I'll hold it. I'll hold it.
Okay.
I'll shut
Okay.
up. Thanks. Bye.
All right, great. I'll press on. So the bulk of the presentation, we're going to talk through 5 key facts about Husky, which again is Medicaid and CHIP. The first is Husky is the major source of healthcare coverage, providing medical, behavioral, dental, pharmacy, long-term services, supports, and transportation to approximately 1 million adults and children. That's the kind of who we serve, is the first fact I want you to take away. Husky Medicaid consists of 3 separate eligibility groups. And I'm not going to read every word on the slide. Don't worry. But highest level, Husky A, Husky C, and Husky D. You might wonder what happened to Husky B. Hold on, that's on the next slide. These are 3 different groups with different ways of qualifying for Medicaid. And there are different income limits, and there are different average costs for different people, depending on how they qualify. So for example, Husky A is what many people, old school, think of like traditional Medicaid. These are parents and caregivers, so moms and kids, dads and kids, families, kind of very colloquially, and the income limits are listed here. So Husky A provides approximately 550,000 coverage to 550,000 parents and caregivers and their children. And the income limits are located over here. On average, members on Husky A are less expensive, in part because children tend to be less expensive than especially elderly adults. It's just giving you some sense of the cost of the program. Husky C is for older adults and individuals with disabilities. And the income limits are quite low are significantly lower for Husky C than, for example, for Husky A. Separately, and we can have a separate one-on-one on this if it's helpful. Some people can qualify for Medicaid through these waivers, where home and community-based services programs have higher income limits to get on Husky C. Husky C represents a smaller number of people. On average, members of Husky C are more needy and have higher costs than other members. And Husky D is the expansion population. These are eligible adults 19 to 64, typically who don't have children, because if they have children, they would qualify for Husky A. This is 355,000 adults who don't have children or specified disabilities. And these members are about average in terms of their costs. So that's Medicaid. As I mentioned, CHIP is a program for covering children whose family income is modest, but a little bit higher than would qualify for Medicaid. We have 2 different bands. Band 2 requires a premium. So the family needs to pay a little bit of money every month, and the details of who qualifies are on these slides. And again, sorry, Representative Walker, for not sending these in advance. We'll make sure these are in your inbox, so don't feel like you need to take screenshots or things like that. Just trying to give you a flavor for the income limits and who qualifies. So that's kind of who qualifies. Now I'm going to switch gears and talk about what we cover. So under Medicaid, there are mandatory services and optional services. Mandatory services are things that the federal government says you must cover in order to receive federal support. And these are things like inpatient hospital, outpatient hospital, family planning, medical transportation, and something that I'll come back to later, which is EPSDT. There's a link to the full list of mandatory services in case you really want to geek out and see what everything the federal government requires that we cover. There are then optional services that states in their discretion can decide to cover or not cover. And these include things like prescription drugs, dental, hospice, personal care, care management, home and community-based services. The full list is in the link. Connecticut has elected to cover a very broad range of optional services, and we receive federal match for this care. And in general, Connecticut is very much a leader in the comprehensive nature of the optional benefits that we cover. Just one concrete example, Many Medicaid programs don't cover adult dental, and we do. This is just an infographic on, this is a member-facing infographic on kind of what services we cover. So I'll focus on the Medicaid portion. We cover medical, behavioral health, pharmacy, translation, sign language support, vision, dental, and non-emergency medical transportation. I'm going to get a little bit in the weeds on one topic that I think is important for you in your role as legislators to understand, and that's on, okay, well, what if we want to cover new things? What if we want to cover new services? Or we want to change the way we pay providers or set new rates, things like that? What needs to happen? And before I get into the details, just know that because the federal government is paying for a chunk, more than half of the Medicaid program, they want to be able to say yes or no to important changes that we make in the program. And I think rightly so, because they're paying for most of the bills. There are two legal routes for us to make a change in what we cover, how much we pay. One is known as a state plan, and the other is known as a waiver. A state plan is an agreement between the state and the federal government describing how we administer our Medicaid and CHIP program. It's basically a contract between the state and the federal government for what we're going to cover. And I won't go through all the different sections, but some recent state plan amendment changes include last session an increase in adult dental and endodontic rates, and then a SPA that we've done on substance use disorders. And I'll get back to in a moment the role of the legislature and the executive branch in doing SPAs. The second route is through a waiver, and waivers allow the federal government to waive, to kind of undo some of the rules that govern Medicaid program. So one example is Covered Connecticut, the program for that provides Medicaid-like coverage for people whose income are a little bit too high. We did that through an 1115 waiver because that was kind of a change to the regular structure of Medicaid. Or for example, many of our home and community-based services waivers, and I'll touch on those in a moment, are waivers as well. The key thing is that both require federal approval, rightly so, because the federal government's paying most of the bills. So when we collectively, the executive branch, the legislative branch, make a change, we do so under the federal framework that they've established. And then just maybe concretely, just to help understand, if we collectively wanted to think about covering a new service under Medicaid or under Husky, here's what would need to happen. First, it needs to be permissible under federal law, at least to receive federal match. So there's some things that the federal government say, you cannot use federal dollars to cover those services. And so, we would not be able to get federal match under this. The department would identify the service that would meet the member needs. And then we would estimate the fiscal impact, thinking about the number of members, the rates, things like that. The administration would approve, pursuing the service. The legislature would need to enact authorizing legislation if needed and appropriate funding. And then, we'd go from there. There's some things that Medicaid does not cover, at least with federal dollars, or at least without a waiver. These include things like services that are not covered under federal law, research, experimental care, most out-of-state care with some important exceptions that I've outlined here. So, and then pilot projects or projects that only touch on specific geographic areas, we would need a waiver to do this as a general rule. So we could not say we're going to cover this service, but only for people where I live in New Haven, but not other areas. We wouldn't be able to do that under federal law unless we got a waiver. So let me pause there, see if folks have any questions on kind of whom we cover, what services we cover, and how one makes changes to that list. Okay, I don't want to be too professorial, like just going on a long lecture here. I definitely want this is intended to help bring you all up to speed. Okay, so the second key fact is that Husky, I really think of it as an investment that we make and the health, economic security, school and work readiness, and independence of people in Connecticut across the lifespan. And I use that word investment very intentionally, because and I'll explain why in a moment. But briefly, investment is something that you put money into, and then you get a measurable, concrete thing out on the other side, and that's very much how I at least think about the Medicaid program. I'm going to start by talking about kids. And I should say I'm a social scientist by training. I'm an economist. I have a PhD. I'm a research guy. So these two slides are going to be a little bit more researchy. But in my view, especially in the last 5 years, there has been very credible social scientific research that demonstrates that covering kids with insurance, health insurance, improves their long-term outcomes. And it's not just about making kids healthier. It also aids in their growth and development, school readiness, and their ability to become actively engaged citizens in the future. And as I'll show on the next slide, there is research that I think shows very clearly, causally, that having Medicaid coverage in children has long-run impacts decades later, including making children more likely to go to college, increasing their wages, making them pay more in taxes, decreasing hospitalization rates as adults, decreasing rates of obesity, and decreasing the number of children that people have before the age of 21. So when I think about Husky as an investment, it's that. It's we're putting money in, we're providing health insurance for children, and then when you follow them over time, a decade, 2, 3 later, you see all of these better outcomes that I think are really important as citizens, as taxpayers, as representatives of the state. So without getting too far into the details, how do we know that? How do we know that Medicaid has this return on investment? Because as we all know, correlation isn't causation, right? So in the last several years, researchers have zoomed in on so-called natural experiments, where some states will expand Medicaid, but they'll do so very discontinuously. So children born after a particular date will get access to expanded Medicaid, and children born before that won't. That is a discontinuity, right? Children who, if you look on either side of the discontinuity, they grew up in the same neighborhoods, they have the same family income, but one child gets Medicaid and one doesn't. And by zooming in on that discontinuity and then following those children over time in data sets like our tax records or hospitalization records, you can zoom in and really understand the causal impact of Medicaid coverage on outcomes decades later in life. And I won't go through all the details because I did in the previous slide, but that research design, in my view, is very credible and has demonstrated conclusively that covering kids has these better outcomes decades later in life, including one I'll just highlight because it's budget season, paying more in taxes. And that's really what I think about when I say call it an investment. That's really the investment that I think about. And just one quick example of that. Covering Medicaid for children by one study, for every dollar that you put in, you put aside all the health benefits and all the good reasons for covering it. Just if we're trying to maximize tax revenue, you get back 58 cents of that just in the first decade of adulthood, much less beyond. And so that's the frame in which I use the term investment. So that's children. How might Husky achieve those long-term improvements in health, education, and earnings? Well, I think it's basically providing the care that kids and their families need to get a good, strong start in life, starting from family planning services in pre and postnatal care, pediatricians, preventive dental, behavioral health, developmental screenings. I think all of those portions of the program are part of the reason that we see that return later in life on outcomes like going to college and earning higher incomes. In particular, for kids in Medicaid under federal law, there's something known as EPSDT. And I'm not going to read every word on this, but at a high level, federal law requires every Medicaid program for kids to provide comprehensive services that furnish appropriate and medically necessary services needed to correct and ameliorate health conditions for kids. And these are things like screenings, diagnostics, and treatment. And so this is another way of saying that for kids under federal law, the Medicaid program really is truly comprehensive in what we cover. And I think that's an important part of why we see those returns later in life. So that's kids. I'm going to switch gears just for a second and talk about adults. There is, in the last decade, there's been similarly credible research showing, I think very convincingly, that providing health insurance for adults has measurable impacts on important health outcomes, including something as severe as mortality, as well as non-health outcomes like reducing bankruptcies and financial hardship. The sources of evidence come from looking at Medicaid expansion under the Affordable Care Act. Most states like Connecticut expanded Medicaid to cover childless adults up to 138% of federal poverty. This research comes from looking at the Affordable Care Act exchanges, where some people get nudged to join the exchange and some people don't. And you can see that people who are nudged to join the exchange are less likely to die because they have coverage. And we see this with Medicare, where when you turn 65, you get comprehensive coverage. And we see better health outcomes for those populations. So this is a long way of saying, I think the research showing that giving people health coverage is important for example, reducing mortality or reducing bankruptcies. It's an investment that we make in our health and financial security. And so we've talked about kids, we've talked about adults. I'll just touch briefly on older adults and people with disabilities. We very much try to take a person-centered view where we're thinking about the services that we provide older adults and people with disabilities. And we always want to start with the member. What does she need to be successful? And sometimes that's screening. Sometimes that is having a care plan or covering health insurance. The thing I'll touch on here is something known as long-term services and supports. Long-term services and supports are either nursing home level care, institutional care, or home and community-based services that helps people who have a high level of need live meaningful lives. And as I mentioned at the beginning, Medicaid, in contrast to Medicare, provides that comprehensive long-term services and supports coverage for older adults and people with disabilities. As I mentioned, Husky Health covers home health care and nursing home care for people on waivers. We encourage self-direction under community first choice. And one of our big goals for our members who want to live, who kind of are at nursing home level of care, but who want to live in the community, we have a compelling goal in helping them transition from institutional settings to living at home. Mostly because from a dignity standpoint, if people want to live at home, that's good. And also it's less expensive for the state. And so if we can help people live in the community, we really want to help them out. And we've helped transition 6,600 people from institutional settings to the communities. So let me pause there. That second one was on that kind of the investment that Husky makes in the health, economic security, the readiness and independence of people across the lifespan. Any questions on that section?
Yes, I'm sorry, I can't figure out how to raise my hand on this.
Go for it, please. Yeah.
The information, the outcomes that you had for children, can you tell us how long that study was, what the impact of it was, how long they went back and reviewed it?
Yeah, it's a good question. So let me start by saying an obvious statement that I know you know, but just to say it, to look at long-term outcomes, we need to look at things that happened a while ago, right? We can't look at what covering kids in year 2018 on their earnings at age 40 because
they don't exist yet.
Time.
Exactly, right. It's assumptive and not
exactly. So these policies necessarily need to look at policy experiments that happened a while ago for the kids to get old enough to see those longer term outcomes. So most of these studies that I'm talking about looked at kids that where they got Medicaid coverage in the 80s and 90s, and then they followed them over time in their 20s, 30s, and beyond. And how do you follow kids over time like that? It's hard. People move, people change states, etc. The best of these studies, the ones that I've linked here, use administrative data like the IRS data or hospitalization records data, which are more complete, to have that longitudinal view. So, if a kid got Medicaid in the 90s, let's make an easier example. Yeah, if a kid got Medicaid coverage in 1994, today they'd be in their late 30s, and you can look at those longer term outcomes like fertility, like earnings, like going to college. So that's sort of how those work. And so these studies tend to look at children, decades later, and that's what I think is really cool about being able to see that when we make those investments, we see returns not only in healthcare, but then in college and education and earnings in adulthood, which I think is pretty powerful.
Perfect. Thank you.
Representative Osborne.
Thank you. I was wondering what coverage is defined as, because is it coverage when they're only covering 10% or 40%, 47% of a particular cost?
Yeah, really good question. Every state does its Medicaid program a little bit differently. But as a general rule, in part because of EPSDT, for kids, Medicaid in every state, even in states that have pretty stingy Medicaid programs, cover the vast range of services that kids need, and do so with no, or in some cases, a tiny bit of cost sharing. So basically, Medicaid is free. For kids, at least, Medicaid covers the vast majority of services that people need, and at no or almost no cost to the family. And you're on mute, Representative.
Apologies. I should have clarified. This was as to your use of the word coverage. There's a federal funding coverage. So again, I'm specifically speaking to, we have an ambulance problem in my town because right now Medicaid is only reimbursing at 47% of the ambulance services, and our ambulance is 100% self-funded, no tax dollars. And they're going under because they're getting 47% back on the dollar for the services that they render for Medicaid. And they get like 85% from Anthem, which is pretty good.
Yeah, great. Okay, so really good question. And I suspect I'm gonna get a lot of questions on the rates that we in the Medicaid program pay our providers. And it's a good question, and Representative Walker teed that up at the beginning. If it's okay, maybe let's hold the rate questions. I think they're really important. We will have a lot of time for Q&A. I think it'd be helpful to cover that after we've gone through a little bit more content.
Great.
Folks, but it's a really good question. I get where you're coming from.
Appreciate it. Thank you.
Hi, Representative.
Hi, good morning. I just have a question on what you were discussing around the money follows the person. And I was interested in just learning a little bit more about that. And then when you say, because this is the high needs population, as far as elderly and individuals with disabilities, I'm curious what it looks like when you say you've helped 6,600 people to transition to the community, what that looks like. So if you could just expound upon that a bit, I'd appreciate it.
Yeah. Bill, I can take that, or Bill, do you want to take that one and I can fill in?
I would start by saying, well, first, good morning, everyone. Bill Halsey. There are slide decks available, and there's a whole site available on Money Follows the Person. But in short, it is a comprehensive assessment of somebody's needs while they're in a nursing home to be successful in the community, and then wrapping them up in those services as a transition plan to move them into the community, support them in the community. It is quite a comprehensive assessment and process, and it can take months to come up with an appropriate plan for moving somebody from a nursing home into the community. So this is a multi-year project, and over those many, many years, we've moved thousands of people from a nursing home into the community. But we can also link you to multiple slide decks and a whole site that explains Money Follows the Person in pretty significant detail.
Okay, yes, thank you. I would appreciate that. Do you find that most of the people, like of the 6,600, are the elderly population or the disability population? How does that break down?
I would like to refer to the slides before I answer that. I think it's a mix. But I just want to confirm that.
Okay. And okay, I'll follow up with that a little bit later. Thank you.
And the only thing I'd add to that, I think we got this, but it's very much at the member's choice, right? If she's living in a nursing home, if she wants to say that, that's her choice, but there's a subset of people who would like to live in the community. And maybe just a little bit more history. Medicaid, I mentioned nursing home was a mandatory service. So Medicaid used to not cover home care, home community-based services. And rebalancing is this kind of giving members the choice to receive the care in the setting that they want, whether that be an institutional setting or a community setting. And that is important for dignity. And it's also, there's a substantial cost savings associated with that. So it's kind of for the members who want to do it, it's a win-win.
Yeah, I'm really interested in this because I do recognize, and I don't want to spend too much time, individuals with disabilities are often looking to be in community-based or different types of settings, but it can be quite a challenge to find some, especially the quality in which they're seeking. So I'm interested in learning more. Thank you.
Thank you, Representative. And I think we can take one more question, but it's important that we get through the presentation so members have an opportunity to ask about everything in its totality. Yes, Representative Dathan.
Thank you very much. And just to follow on, I'd love to hear more about money follows the person, so maybe we could talk a little bit separately. I understand that we have a higher FMAP with that program because it is temporary, and just wanted to find out kind of on average what that sort of time period is, and so that we can understand that sort of dynamic. I know other states have much more comprehensive money follows the person programs like New Hampshire and Massachusetts. And I'm trying to do some research to find out a little bit more about that, and maybe we can have a separate conversation offline.
Yeah, or we could bring it to MAPOC. Great, yeah, I'd love that. And I'm sure I know that there are things that we could do better. I do know that Connecticut is at least is measured by the number of people that we help serve relative to our population. We are a leader compared to other states, but I know there always are things that we can do better. So I love that. Okay, I'm going to press on. The third section, this is going to be really quick. It's just reminding you all it's a federal state partnership. Just reminding you of the federal aspect of all of this, at least if we want that federal match. Too many words here. I'm not going to read them all. I just wanted to give you a little bit of insight into how the federal government thinks about Medicaid. And I've included the authorizing statute for Medicaid and CHIP here. So it's medical assistance, families with dependent children, aged, blind, disabled people, providing medical services and rehabilitation, other services. The federal government, the Medicaid Act requires that each state administered in the best interest of the recipients. And so when the federal government is thinking about approving a waiver on our standpoint, obviously the Biden administration thinks about that differently than the Trump administration did, than the Obama administration, but they're thinking they have to always go back to what's in the best interests of the recipient. And that's the test that they're thinking about when they're approving waivers, in addition to other tests like the budget. CHIP is very similar to Medicaid. It's covering uninsured children whose families are modest but a bit too high. And just to remind these key facts, just because I think they're so important, the federal government pays most of it. The state plan and waivers are the legal documents by which we can cover things and get that federal match. And then changes to that require agreement between both the federal and the state governments. And some of those agreements are extremely routine. Some of those agreements are extremely, they're a real negotiation and take months. So just an example, the 1115 waiver on covered Connecticut took many, many months of negotiations with the federal government, between Connecticut and the federal government, and kind of a back and forth on what are we covering, how much is the federal government bearing financial responsibility. And so I just want to give you that picture that some things are very straightforward. The feds will say yes pretty much right away, and some things are much more of a negotiation. My colleague in California, who recently expanded Medicaid to cover some services for inmates shortly before they leave the institution, that was a multi-year negotiation between California and CMS. Okay. Fact 4, and this is going back to one of the questions on the ASO model and how that differs from other states. Connecticut manages its own benefit through managed fee for service, as opposed to something called capitated managed care. And I want to teach you or explain what we do here in Connecticut, how it differs from other states, and some of the pros and cons. So this is the slide you all have seen. Just a reminder, we hire 3 ASOs to administer our medical, behavioral health, and dental benefit, as well as a transportation vendor. Our model of what we have something called a managed fee for service model here in the middle. That's in contrast to a traditional fee for service model or a capitated managed care organization. I want to spend a moment just walking through that. So in a traditional fee for service model, that's like traditional Medicare. My mom's on traditional Medicare. She has a Medicare card. The federal government determines the rates that doctors get paid, how much a nephrologist gets for a visit. The federal government determines what benefits are covered. They cover this service, but not that service. And then my mom is basically free to do what she wants. There's little care management and there's little utilization management. My mom has to choose her own doctor. She can do there. If she kind of falls between the cracks, the federal government isn't calling her, reminding her to take her medicines or see a primary care doctor. It's kind of very unmanaged. Connecticut's model is in the middle, managed fee for service. This is the model that we at Husky use. It's also the same model that most large or self-insured employers use, like Xerox or Amazon. Here, the payer, the state, in our case, or Amazon or Xerox in their case, they set the rates, how much doctors will get paid, and the benefits, whether we cover chiropractic services, whether we cover acupuncture. We, whether it's the federal government or Amazon or Xerox, hire an ASO who then performs things like care management and utilization management. But critically, those organizations are not at financial risk. Much in the same way that Amazon may pay Aetna a per member per month fee to do customer service and do care management, at the end of the day, Amazon's paying the bills. Similarly, the Husky program, the state hires these ASOs to do care management and utilization management, but at the end of the day, we're at financial risk, we're paying the bills. I want to contrast to that to managed care. And most state Medicaid programs are primarily Medicaid managed care, and Connecticut's used to be before we transitioned to this managed fee for service model. In Medicaid managed care, the payer sets a broad regulatory framework. For example, you must cover pediatric services. The state will say that. And then the state pays what's known as a capitation payment to a managed care plan. So, the state of Arkansas might pay Centene, I'm making this up because I don't know the details, but may pay Centene $4,000 per kid per year that Centene enrolls. And then Centene has this $4,000, and if those kids cost more than $4,000, Centene loses money, and if those kids cost less than $4,000, Centene makes money. That managed care organization sets the rates that providers pay, establishes a network, which doctors are going to be in or out of network, does care management, utilization management, and other services. So just to zoom in on these two models, just to help you understand how things work here in Connecticut, I was going to contrast what we do here in Connecticut, the managed fee for service, with the capitated managed care. So in terms of payments, here in Connecticut, we don't make payments to managed care organizations. Instead, we, the state, are at financial risk. So for example, at the beginning of COVID in 2020, when we all stayed home and didn't go to the doctor, healthcare utilization dipped, a huge amount, and that saved the state money. I'm not saying it's a good thing. People should, we want people to go to the doctor, but that saved the state money. In contrast, in a managed care environment, those managed care organizations get paid a flat monthly fee, and depending on the details, the state may not have quote unquote saved that money during COVID. In terms of the financial risk, if people consume more or less healthcare than expected, Connecticut, we the state assume that financial risk. In a managed care environment, the Medicaid managed care organization assumes at least some of that financial risk, although there often are risk porters, reinsurance, and lobbying that transfers some of the risk back to the state. But in principle, at least some of the financial risk is pushed off on those financial companies. In terms of plan design, here in Connecticut, we have standardized statewide coverage. It doesn't matter what town you're in. We're either going to cover a service or we're not. The utilization management looks the same. We have the same drug list, preferred drug list. Everything kind of looks the same across the states. In a managed care environment, different managed care organizations make different choices. And so depending on if you sign up with Aetna, Molina, or Centene, you'll get a kind of a different experience, much in the same way with private insurance. If you sign up with a different carrier, you'll get a somewhat different experience. And then in terms of the data, Connecticut has a fully integrated statewide claims database. In the managed care environment where things are more fragmented, the data is more fragmented as well. So hopefully that helps. I know Representative Walker, you in particular wanted to touch on the ASO model and what that means. Let me pause here for questions and make sure I'm answering kind of how Connecticut is structured, how we manage our benefit.
Thank you, Guy. I want to go right back to my question. So we are a managed care state. We use ASOs.
Yes.
Let's say California. What is California?
California, and you're going to be able to stump the chump pretty quickly because there are 50.
Well, I'm just going to go to California.
But generally, California, they're overwhelmingly managed care. For some of the, and I don't know all the details of California's program, but for some of their populations, they're in managed fee-for-service or fee-for-service. So, and again, I don't know all the details, but probably their nursing home residents may or may not be on managed care, but their moms and kids and childless adults are overwhelmingly on managed care, for example.
The reason why I raise that is that when we look at other states and we say, well, California has this or so-and-so has that, we've got to understand the Medicaid structure of the state in order for us to really have apples to apples. So I just kind of wanted to bring that up because somebody brought up another state before, and they don't have the same healthcare system that we do. So I just wanted
True. And this is a total cliche, but I'm going to say it. There's a cliche Medicaid that says if you've seen one state Medicaid program, you've seen one state Medicaid program, in the sense that they really do differ. They really do differ. So Representative Walker, just an example to build on your statement. You might think, oh, we really straightforward to compare per member per month cost across states. Like how much is Connecticut costing our members versus Vermont versus Massachusetts versus California? Seems like a very straightforward thing to do, and we could do that. But it's not as meaningful a comparison as you'd think because different states cover different populations. And so, for example, if Connecticut, and I don't know the details of California's program, but if California covered fewer, had a kind of more restrictive benefits for high cost people with disabilities, their per member per month costs will be lower. That doesn't necessarily mean that they're being really efficient in managing costs. It may mean that, but it also may mean they're covering a different set of services for fewer people. So it I guess the great thing about Medicaid is we can always look to the other states and territories for what they're doing, and that's a great source of information. It just, you always need context because we cover different people, different populations with different services. And I know we're going to talk about rates during the Q&A, and I'll just say, because I know it's really important. Here in Connecticut, the state set the rates that we pay. So for how much a dermatologist get, that's set by the political process, by the legislature and the governor. In most states with capitated managed care organizations, it's a little bit more indirect. The state will send Molina or Aetna or Centene that $4,000, whatever it is, and then they will set the rates for dermatologists. And those rates are proprietary. Those are trade secrets from the insurance company. And so part of the reason why it's more difficult than you might think to say, well, how much are we paying versus Massachusetts for primary care doctors or dermatologists is most people in Massachusetts get their Medicaid through these managed care where you can't go to a website and look it up. It's secrets. I know we're going to talk more about rates, but I just wanted to bring everyone in the weeds just a little bit there because it's more complicated than you might think at first blush.
Thank you.
Okay, great, Representative, go for it.
Good morning. Could you go back to the last slide?
Of course.
So again, just to be clear, we, Connecticut, are under the managed fee for service, not capitated.
Correct.
Okay, so under managed fee for service, if Connecticut, say a doctor says, I'll just make up numbers, that the procedure is worth $1,000. Connecticut turns around and says, no, that's only worth 500, and that's all we're going to pay. Does the doctor have to accept that, or is he going to try to collect more from the patient or something?
Great question. The doctor does not need to accept that. So a doctor can choose to participate or not in the Medicaid program, and not all doctors do, right? And when we're thinking about access, that's an important fact. Just for example, I mentioned increasing the adult dental rates. I know the legislature did that last session. And I'm not a member of the legislature. I won't speak, but I think part of the reason why some people were advocating that was not very many dentists were taking Medicaid. They weren't taking Medicaid patients, so it's hard to access the benefit. So they don't. It's voluntary, but the doctor cannot balance bill the patient. They cannot say this should have been $1,000, so you, the patient, owe $500. It's not allowed. Okay, great. Just in the interest of time and making sure I have time for Q&A, I'm going to go through the last section and then touch briefly on unwinding, then we'll open up for Q&A. So this last section is we've implemented a range of reforms that have helped improve costs and improve care and control costs. I'm going to go through this quickly, and again, we've sent out the slides, so you'll have all this data, but this is kind of the finance and a little bit on the quality side of what we're doing. On the quality side, in last month's MAPOC, we walked through a more comprehensive view of how Connecticut is doing relative to other states in terms of quality measures. I won't rehash that discussion. If folks want, email me and I'll send the deck and a link, and I'm happy to walk you through it one-on-one. Overall, and of course, there are things we need to do better, and we identified those in the MAPOC presentation, but I guess the one slide I want you to take away is that on measures of quality, in general, we're doing quite well relative to other Medicaid programs, which I think is something we can be really proud of. We definitely have room to improve, but overall, we're doing better than most states, which I think is great. On the dollars and costs side, we are now net budgeted, which means DSS receives an appropriation from the state for the share of the Medicaid expenditures that the state owes, and then we get the rest of the money from the federal government. Over time, and I'll have a little bit of data on this just in a moment, the state share on Medicaid expenditures has remained steady. And we get most of our money from the federal government. And then last, but I think really importantly, our per member per months have been quite stable, which is great. And our what we pay on administration, it's like my salary, Bill's salary, the building, all that stuff is much lower than most other states. The overwhelming majority of the money in Medicaid goes, rightly so, to directly paying for the medical care of our members. And I bring that up because we're always trying to think about how to save costs and how to operate more efficiently. And the overwhelming majority is in the medical care that we provide. And so I always think when we're thinking about how to be more efficient, it's about keeping people healthy, trying to prevent expensive hospitalizations from taking place is the place where the real money is at. This is just a quick view of our budget. This is the total expenditures in millions that are directly reimbursed from DSS Medicaid out the door. And that totaled $7.244 billion in fiscal year 2022. You can see this change between the different the net appropriation versus gross appropriation that happened in 2014. The total spending on Medicaid, including other things that are outside of what DSS directly reimburses providers, things like certified public expenditures, hospital supplemental payments, is higher at $9.2 billion. And in next month's MAPOC, we're planning to walk through a comprehensive walkthrough of the budget where we spend our money, because it's a huge line item, and I think it's important to provide transparency on it. What I'll do here just briefly, I'll just touch on the big slices of the pie, just so you get a feeling for where we spend our money. The biggest slice is on hospital services. The next biggest slice is on nursing homes and long-term care facilities. Waivers and community first choice, that's what we talked about earlier, is the next largest slice. And then physician expenses, things like the primary care doctor, the nephrologist, the dermatologist, is is 11.2%. There are other things here, pharmacy, the important role that FQHCs play in the budget, and then the administration, that's, you know, overhead, those are the nurses that we call to do care management, utilization management, that's 1.6%. I think that this pie is important just because if you're thinking about how to get efficiencies, it's useful to get the total picture. I'm not going to walk through the slide in detail. Again, we'll send it to you. This is just giving you a sense for how these shares have changed over time. And they're pretty steady over time. There's some fluctuations, but I just want to give you that kind of that transparency. And then last but not least, before we get to the wind down and the Q&A, I just wanted to show you the graphs on the total enrollment in the Husky program, and then the per member per month fees. And in general, our per member per month have been growing pretty slowly, in part because the public health emergency I'm going to get to next, we've kind of retained our lower cost members. And so that's kind of helped us maintain our lower per member per month growth. Great. So you've almost made it to the end. I have one more slide. And then I'm going to open up to general Q&A. This last slide is on something really important. That sounds really technical. It's the wind down of the continuous enrollment portion of the public health emergency, bureaucraties. What does that mean? And I think it's really important for you to know this because this is going to impact your constituents in, I think, a very real, direct way. So I want to make sure I'm educating you about it. Since COVID, since March of 2020, actually, let me start back. In general, before COVID, when one's income went up, if your income got too high, you would get disenrolled from the Medicaid program. It's a means-tested program focusing on people with specific incomes for specific eligibility groups. And if your income went up over that threshold, you would lose Medicaid coverage. At the start of the pandemic, Congress decided to make a change, and they gave states very big financial incentives, which every state, including Connecticut, has taken, to keep most people continuously enrolled in Medicaid. So what that means, and the reason that they did that, they didn't want people losing their health insurance at the beginning of a pandemic. In part, there was huge employment disruptions at the beginning. You know, there's a lot going on, and they didn't want people to lose healthcare coverage. What that means is that since March of 2020, basically no one has gotten disenrolled from the Medicaid program, both here in Connecticut and in every state across the country. Enrollment in Medicaid has grown substantially, 26% nationwide, much lower here in Connecticut, in part because we had pretty generous coverage beforehand, but still 15.7%. There's been substantial growth in the program because no one's been disenrolled. And approximately 45% of people on Husky A and D are on a public health emergency related extension. We've known for a long time that at some point this was going to end. And when that ends, people will, if their incomes have gone up, they will lose Medicaid coverage. We're kind of going back to the way it used to work. This is a really big deal though, because both people whose income have gone up, they will lose Medicaid coverage, but people whose income hasn't gone up, but they've kind of fallen out of the habit of requalifying, of talking to the government and demonstrating that they still qualify, could lose coverage as well if they don't take action. And so people are talking about this as the biggest change in the health insurance structure since the Affordable Care Act. It's a really, really big deal, this unwinding. In terms of when it will unwind, Congress passed the omnibus spending bill in late last year, and they said the continuous enrollment requirements of the public health emergency will end on March 31st. And so that means that the Department of Social Services will start initiating redeterminations that could on March 1st of this year. Okay, what's our plan? This is a really big deal. You know, tens of thousands of people will lose coverage. Hundreds of thousands of people will need to re-qualify for Medicaid, something that they used to do routinely, but may have gotten out of the habit over the last 3 years. Well, first of all, we have a 12-month staggered process. We're not making everyone renew on the first day. That would be chaos and confusion for members, and our call centers would be overwhelmed. So we're doing it in a staggered approach, basically a first in, first out approach. We We've been communicating with members throughout the pandemic on the importance of updating us with their contact information so we can contact them when this happens. We of course have covered Connecticut, which is a great option for people who make a little bit too much money for Medicaid. And then in terms of the outreach itself, we have been reaching out on social media, posters, billboards, mailers, emails, calls, provider bulletins, and community partners. And every month for the last several months in MAPAC, we've been describing the plan, what we're doing, the risks to all of that. I know we're short on time, and I do want to make sure to answer general Q&A, including on provider types, but I'm bringing this up because you as elected officials, I predict that constituents, despite all of our best efforts, some constituents will fall through the cracks, won't understand, they will have forgotten, they'll be confused, or at least so healthcare is really confusing. And I wanted you all to have context on why this is happening and what the plan is. The most important call to action, I guess the two most important calls to action for your constituents is, first of all, don't panic. We're doing it over 12 months. So it's not everyone right away, but then when it's your turn, we will communicate to you on your next steps, and that basically involves going to Access Health CT and walking through a simple process to determine whether you qualify for Medicaid or the exchange or things like that. Okay, my very last slide before I end it and go to Q&A is just I want to go back to this slide on the investment. I'm not going to read every word again, but when I take a big step back and think about the passion I feel for the work that we're doing, that we all are doing, it really is this investment that we're making in the future citizens, taxpayers, workers, leaders of our state. And Medicaid covers 1 in 4 people in the state. It's the single biggest budget item. And I think we all have a shared interest in making it fair, efficient, and run well. And anyway, I thank you all for your interest, and I look forward to your tough questions. So I'll stop sharing, and we can take it from there.
Thank you, Guy, and really appreciate it. And just to underscore your last point, my understanding is through the redetermination process, as many as 430,000 Connecticut residents could lose their health insurance coverage starting this March at 30,000 patients a month for a year. Is that all correct?
That's correct. With the clarification center, that number would be if they don't take action, if they don't go through the redetermination process that we have been nudging and encouraging them to do. So that's that's very much a worst case scenario. I certainly, we will not have collectively not done our jobs well if 400,000 people lose their health insurance, but that number is to try to show the magnitude of the importance of getting this message out to our constituents and members.
Thank you. And it's going to be all hands on deck, and we're going to need all of our providers to take part in making sure that their patients don't lose coverage. Representative Walker, I see you with your hand up.
Thank you, Senator Lesser, and thank you, Guy, for this presentation. And there are questions, I'm sure, but I want to go to where Senator Lesser left off, because we are hearing and seeing that already from our constituents. So the panic has hit, whether you say it's going to happen on March 1st. I think it's already hit for a lot of backroom stuff that happened that didn't happen over the last 3 years. So one of the things that I heard, first of all, I was told, and the number of hours and access for going into the office has been reduced. Is that correct?
It's a good question, and I'm going to answer as much as I can. I want to do the proviso that I don't oversee our call centers. It's a very bureaucratic answer, which I know everyone should hate. So I'm not going to know all the answers, but we do not offer. The department do not offer for most of our members walk-in service on Wednesdays, and that's to protect the staff time to cover emails and applications and stuff like that, non-walk-ins. And that, relative to how it was several years ago, I think, Bill, correct me if I'm wrong, because I don't want to say anything that's not correct. I believe the Wednesday thing is a change to how it used to be, in the past. Bill, is that right? Is that right? Do you know?
I believe it is.
I believe it is. But I also think I heard Peter say that there are exceptions for
There are.
people who can absolutely
emergencies.
walk in
Yeah,
on Wednesday.
yeah.
Okay, so I guess my question, this is for us as legislators. When we had unemployment crash on us, we had to provide a lot of temporary people to help manage that unemployment population. I don't think that reducing the hours or days should be an option. I think we should be providing you with the support teams to help you in the backroom operations, so that, because there are a lot of people that depend on this healthcare, as you said, over 1 billion people. Oh, I'm sorry. Yeah, no, 1 million people. So $1 billion, million people. Okay, mix them, million. But anyhow, the issue is the gates are going to be flooded, and Access Health Connecticut is a nice idea, but it's not available for all of our constituents. So I would just ask that we try and come together quickly to come up with something to address it. And I think Senator Lesser, Representative Gilchrist, and Representative Nuccio, and Senator Berthel, and Senator Austin, we're all ready to start talking about that, because we can't afford to have our population become more ill because of the fact that they can't have access to healthcare. So I thank you for bringing that up. My only other question was on two terms that I see all the time, which is medical necessity and zero-based budget. No, not zero, but when neutrality, budget neutrality. Can you just explain those two things just in 30,000 feet, but
Great.
just so that we can generate a few more conversations with our colleagues later?
Great. I'll take budget neutrality, and then Dr. Richards, if you're on, you can do medical necessity. Dr. Richards is our Chief Medical Officer. So budget neutrality, it's used in different contexts, but the primary context in which it's used in Medicaid are on the waivers, in particular the 1115 waivers. Reminder that 1115 waiver is known as research and experimentation, but it's basically if you want to do something different. For example, I mentioned California, my colleague in California, she in the legislature start covering services for inmates right before they get discharged, so that people get the coverage that they need. That required a waiver on the federal government, because that was waiving 1115 waiver, because that was waiving the prohibition of Medicaid covering healthcare in prison and correctional facilities. Okay, so in the context of 1115 waiver, you need to convince the federal government that it's budget neutral. There's budget neutrality. And so in the example of California, just as an example, that looks like saying, well, if we cover these services, that's going to help these patients, these new Medicaid members, stay healthy. They're less likely to overdose, they're less likely to go to the emergency room. That stuff is expensive. So yeah, it's going to cost some money to cover these services, but we're going to have a benefit in terms of keeping people healthier. And net, it's going to make things budget neutral. Okay, so it just means it's not going to cost us. It can cost us more, but we're saving in another area. Yes. So it doesn't mean that we're taking the $10 that we're spending and we can only spend $10. We have to just demonstrate the impact. That's good. That's exactly what I want to hear. Just one more sentence, Representative, if I might. I won't bring you too far into the weeds, but something like many states are covering, starting to cover housing or food for select Medicaid members who really need it. Like you would think a person with chronic kidney disease who's going to the hospital, crashing onto dialysis, giving them meals. The definition of budget neutrality, the Biden administration is taking a very creative approach to budget neutrality, allowing states to cover things that past administrations, it wouldn't really have passed muster under their definition of budget neutrality. So there's a lot of nuance in exactly how you define budget neutrality. Like you all know, as appropriators and legislators, but there is a window here with the Biden administration to do things that you couldn't do in the past and may not be able to do in the future. Okay, thank you. Brad, are you on? Dr. Richards, do you mind?
I am. Can you guys hear me?
Yes.
Mm-hmm.
Good. And my apologies. I'm just heading to clinic, so I'm actually at the train station. So my apologies if you can't hear me as well. But medical necessity, there's actually a very particular language around it that's in the statute, and I can't tell you exactly the language off the top of my head, but it includes basically it's medically necessary to provide any health services or procedures that a practitioner, like a doctor, would reasonably want to provide to prevent, diagnose, or treat an illness or injury. And there's a few other components of it. It can't be for the convenience of the member. It has to be clinically appropriate. And so just to say, as like a provider, there's certain things that are always, at least at this time, treating someone for diabetes with specific treatments or medications, very much going to be under medical necessity. But on things that are evolving in healthcare, there is often debate about whether something is truly medically necessary or not. And so you guys might be familiar with the new dementia medication that Aduhelm that had come out recently. And sometimes this has to do with, is this a safe drug? Is this going to help individuals or not? And so sometimes things are up in the air and they're still being debated within the medical community. Most things are probably relatively defined, but there's certain things that are not. And there's actually a process for people who are not currently, for things that are not covered to go through a process when they're denied through our medical ASO. So I'll stop there.
Thank you. I think I got it, but I'll follow up with more questions later. I hope he catches his train. Thank you.
One more quick thing. I just want to say, logistics point. I respect all of your time. I know we have until 11:30. I just want to say I will stay on as long as we need to answer questions. So I'm at your disposal.
Thank you, Guy, and thank you, Representative Walker. One question, I do see a couple hands up. Just one question about the prescription drug spend, because I did see a breakdown about hospital services and prescription drugs. Does that, it looked like it was about 10% of services. Can you just talk about how Medicaid purchases pharmacy services, and also does that also capture the spend that's within waiver programs and other types of different tranches of Medicaid services?
Yeah. Bill, do you want to take that one or do you want me to? I'm happy either way.
I will just start by saying that we could do probably a whole presentation on our pharmacy spend and the rebates that we get as the state Medicaid agency. They are significant. So I don't think we have a recent presentation on it, but we could maybe dedicate a MAPOC presentation to pharmacy. It's complicated, but go ahead, Guy.
The only thing, I'm a little bit of a pharmacy nerd by past background. The only thing I'll say, the only thing I'll add is federal law, almost all prescriptions participate in the Medicaid, I forget the term, it's something like the federal Medicaid drug purchasing program, which the federal government negotiates lower rates for Medicaid prescription drugs, and then we need to cover those drugs. So unlike, private insurance, which we're not going to cover drug X, instead we're going to cover drug Y. For the overwhelming majority of drugs, with some important exceptions, Medicaid covers them. But what we can do is we can have some drugs be on a preferred drug list, and that means basically it's easier. It's one fewer step for a provider to prescribe those drugs. On your question on the breakdown of the spending, that 10% of spending in pharmacy does include the waiver members. That's everyone on Medicaid, and in general, Medicaid pays less for prescription drugs than most other payers do, for a variety of reasons. But anyway, happy to do more on that. But hopefully, that answers some of your questions.
And how does Connecticut purchase prescription drugs? Do you do it directly or do you do it through a third party?
Bill, do you want to answer that? The former Director of Integrated Care.
I'm going to have to check on that.
We're part of a consortium. We're part of a multi-state consortium that negotiates that multi-state Medicaid agency that negotiates the purchase of those drugs. And then if we want to do so that's kind of a floor. And then if we want to do something outside of that, we have the ability to negotiate directly with manufacturers. But overwhelmingly, we go with the consortium. We have more lives covered, and so we can negotiate lower rates.
Okay, thank you. Representative Dathan, followed by Representative Nuccio. Representative Dathan, are you still there? Okay, we may come back to Representative Dathan.
Apologies.
Oh, go ahead.
Apologies. Sorry. I'm just transitioning from house to car. Two questions. First of all, I understand the exchange only has one provider now. How are we going to ensure that people who do not qualify for Medicaid and are eligible for subsidies under the Affordable Care Act, how are we going to ensure that they are going to be able to get the coverages that they need so that there's no interruption in coverage? And then my second question is, I understand that there are some website issues for folks who might be rolling off Medicaid, but not understanding how the subsidy work within the ACA. And they're not understanding what those subsidies are until kind of very late in this sort of enrollment process. And how is DSS helping with that?
Great. Both really good questions. Take them one at a time. So on the exchange, on the Obamacare Access Health CT, there are two carriers right now, and for when members are signing up, they have a choice between the carriers, and the theory between having more than one is they can compete on customer service, on the network, things like that, and hopefully help that competition. Hopefully, will help people get the insurance that they need. On the transition question, Representative, which is such a good one, especially in the context of the unwinding, I'll start by saying that relative to other states, Connecticut is in a really good place along the following dimension. We have Access Health CT is the technology platform that people use to enroll in Husky A and D, the vast majority of our lives, and the lives that are most impacted by the end of the public health emergency. Access Health CT is also the same technology platform that people sign up for exchange plans. And that's great because in other states it's really confusing. You have to go to one website, fill it out, and they say, no, you're rejected, then you need to start over. Another, it's like, it doesn't make any sense. So Connecticut, I'm very happy, and I think it makes a lot of sense, is it's integrated. So I think that helps. The website issue that you're describing is real. And I won't derail it. It's just just so folks understand, it's if you're eligible for Covered Connecticut and you're eligible for a zero premium plan, the website does not make that as clear as I suspect many of you would think. This issue, so this is a technology issue with Access Health CT. I've teed it up, I've beaten the drum, I've escalated it. I know they're working on it. I don't want to speak for them on the timeline to fix, but I know it's very much on their radar, and I appreciate your continuing to press on it, because I do think it's unnecessarily confusing for people. And then
I'm just hoping, I thank you very much. I'm just hoping, bearing in mind that we are going to be having to re-enroll folks starting in March. I don't want to have any sort of gaps in coverage for folks who might be transitioning off Husky, and just have some major concerns of this. And I do hope we can get our IT people focused on this pretty urgent issue. Thank you.
Thank you, Representative Dathan. I will just say we the Insurance and Human Services Committee did hold a recent joint hearing on the redetermination of mess crisis. We're going to be holding a follow-up hearing this Thursday, the 2nd, and we're going to be keep holding hearings on this issue until we've figured it out. But also we're going to work with our colleagues and friends on the Appropriations Committee as well. I really appreciated Representative Walker's point earlier about staffing and other issues at DSS that limit access, especially particularly on Wednesdays. Representative Nuccio.
Thank you very much. So I want to be sure that we're curbing the rhetoric where we can, and 435,000 people are up for redetermination, not necessarily they're going to lose benefits. Do we have any indication of, just from trending, how many you think of them will no longer qualify for services based on their estimated new income?
It's a good question, and there are estimates out there. It's tricky because for this, because folks have not been updating us with their information. And they haven't needed to, right? Because of the public health emergency. It's not like folks are telling DSS about all their sources of income. So we have estimates, and I can provide those to you. I will say there is some uncertainty. And that's not a Connecticut thing. That's across the country on exactly what
Right.
the picture.
It's a national level thing. It's not a Connecticut thing.
Yeah.
So
I don't want to provide a number here that or get the range that wrong. So let me add that to my follow-up list, and I'll follow up with you.
I'd appreciate that, because I don't want mass panic out there and it seeming like all of a sudden 435,000 people are going to lose their insurance when I don't think it's going to be nearly that many. The other thing is here in regards to the recertifications of these, I think we need to be very cautious on the information that we're all putting out. Is there something that DSS is releasing and putting out that we as legislators could use to put out on our own networks and social network things to kind of say, if you do receive, if you are part of Medicaid or Husky or any of that, here's what you need to know, starting this, because I think, again, there's some fanning of the flames where this is an orderly process. You've got a 12-month process. It's not like we're slamming people's door on March 1st. It's a 12-month process, and I think if handled well, the rollout will be good. And my question around the rollout is, I know you said you're sharing information on multiple different avenues that recertification is coming up. As legislators, what can we do to quell that and to also get that information out there so people understand that, after 3 years, they're going to have to go through this process again, which is rightfully so. You have to go through the process and revalidate your income. And then more importantly, what is your office doing to kind of bridge that? So do we have an easy platform where, as you said, if you do not qualify, we can then bridge them over to Access CT, which they're already familiar with the format, as you mentioned, but into plans that have the subsidies, and somebody that can sit down and work with them to understand the changes that they're going to be seeing?
Good question. The answer is yes, we do have material, and I will follow. I'll figure out the right way of probably replying all with some of the answers to these questions. But yeah, we can follow up with the website on the material, that the member facing material and partner facing material that we have, that I think could be helpful for your offices, as you get constituent questions and things like that. So let me follow up on that.
Thank you, Gabe. If you could actually send it through Sue Keen and Chandra, the clerks of the two committees or administrator.
I agree. I think, if we can, as legislators, put that on our own social media websites once a month, every month for the next 12 months to let people know they need to be looking for this. And also the hours in which you'll be helping people. And I think that Wednesday thing is important, because I've had questions also about why are we closing the office 20% of the time? And I understand the need for processing, but I also understand that, we've got 435 people who are going to be going through a process that they haven't gone through in a while. So the fact that you're taking walk-ins on that day is something that I think people need to understand and know also. I'm just looking for an easy transition here. These benefits are available for people who are in need. And when you're over that threshold, then you need to go on to the next platform, which is the Access CT. And I don't want there to be mass panic of people that all of a sudden 435,000 people are going to lose their insurance coverage, because I don't think that's the case.
I do, and it's a good call out. So let me follow up, and I'll make sure everyone gets that material on. And thank you in advance for. I think it's a tough message. We want people to take this seriously, but also not to panic, as you're saying. And I appreciate that question.
So we're up against our allotted time. I did see that Representative Osborne has her hand up, but respectful of the committee members' time, we do want to try to keep within our confines. Representative Osborne.
I feel bad.
It's more of a comment. It's more of a comment, actually. And if you are planning on putting 435,000 people through Access Health, I think your number one thing is to go look at the efficiencies and effectiveness of the processes at Access Health, because as an end user, I've got a law degree. I'm relatively bright, and it has got to have been one of the most frustrating, ineffective, Xanax-inducing experiences I've ever experienced in my life. I don't see how, with fewer resources than I have, can possibly manage their way through that. So if you don't want 435,000 people to lose their
Representative, we're at least on my commit, and you've frozen for a second, but
Mine as well. Sorry.
I just want to say, if folks feel that way, you should come and join us on our next hearing on February 2nd. The Human Services Committee and the Insurance Committee having a joint hearing with Access Health to discuss how they plan to address all these folks. And I think it would be a helpful conversation and a good back and forth. I just want to thank everyone. Just want to thank everyone for participating, and Guy, you and your team for helping us understand Medicaid 101. This is a really good conversation. I do appreciate your offer earlier to stay on and answer additional members' questions. I think this will conclude the official portion of the event, but if folks want to have an informal back and forth, I think that would be of interest to some members if there are additional questions.
And thank you for hosting. Thanks, representatives and senators. I just want to conclude by saying what I mentioned in the beginning, that part of my job is to help educate you all on the decisions you'll be making. And if there are things I can do to help you, please let me know. I sometimes can't say yes to everything, but I will always try, because I know educating you is really important for the state and for the program. So thank you. Yeah.
Thank you.
Thank you.
Thank you so much.
Thank you.
It's hard to tell who's staying on because they want to versus they just didn't click the box. Do any senators or representatives have questions or things they want to bring up?
I'm kind of waiting to see if anybody else does either, but I'm looking forward to that information to put out. I think, we should put it out every month. So whatever you have as a best advertisement for people, that'd be the best, I would think, for us to do our job.
Anything else? Okay, well, thank you. Looking forward to meeting you all in person.
Thank you. Have a good day.